Yeah, I'd just like to ask a few questions about causes of MPNs. Would stress be a factor?
Well, it's an interesting question. You know, we do feel that chronic stress it clearly leads to disease, and it probably also increases the likelihood of people developing clonal diseases, whether they be of the blood, so things like MPNs, where there's cells in the bone marrow that start to overgrow with genetic mutations, as well as in other organs, whether that be the esophagus or the lungs or other areas. So, in short, it's tough to prove why one individual patient develops an MPN, but undoubtedly, stress can have an impact on our health and may well be a contributing factor. Now, whether things like that cause a disease or whether they take someone that already has a predisposition and give some initial movement in that direction is difficult to know.
Yes, Professor Mead said there's a challenge with getting ruxolitinib at the moment. Could you explain that?
Well, I mean, ruxolitinib is quite an expensive treatment, as you'll be aware. I couldn't quite see where the question came from, which is hi. So it's an expensive treatment, and there's a process we have to go through in the UK through the National Institute of Clinical Excellence, which approves the use of these kind of expensive treatments in certain disease areas. So currently, the situation for ruxolitinib is that it's funded for patients with myelofibrosis that meet certain criteria, so they have to have higher risk myelofibrosis, but it's not funded for patients with lower risk myelofibrosis who actually can have quite a lot of symptoms and in some cases a strong argument where we would like to use the drug, but it's not funded and difficult to get funding. In the case of polycythemia vera, it is not funded in the UK at the moment, so it is a challenge to get the treatment, and I think that's why trying to run trials where we get access to these kind of new treatments is really, really important, because through the trial, the drug company will typically provide the drug free of charge. So this is what's happening in the Mithridate study, and that's why trials are so important for us as physicians in the UK, where we don't have access to some of these new treatments that are very expensive, because it gets access to these new treatments for our patients through a clinical study setting.
Okay, great. And I think, Marion, there was another question next to you.
Yeah, just thank you for the presentation so far today. In terms of the research being undertaken so far, are there studies being considered for looking at nutrition and diet in terms of what is perhaps promoting the spread of MPN or the disease? In terms of whole food plant-based diets versus animal-based protein sources.
Thanks for the question. Maybe I'll pick that up. These are the kind of things that we want to look at maybe in the fatigue project, to look at how diet impacts on experience. I'm not sure, Professor McMullen, it seems a bit unfair to ask you, but was your question about whether it's a causal or whether it assists with managing the disease?
No, it's more about the actual causal effect.
Cause. So will you be looking at type of diet in the Mithridate, in the Mosaic study?
No.
Okay, that's answered the question. Let's move on. Fine. Maybe. Yes. So maybe we'll take one more question from the room and then see if we've got any online. Yeah.
Okay.
Please go ahead.
Are MPNs hereditary, and are there any studies being done about it?
Andreas, we hadn't heard your voice. Do you feel that you could answer that question?
So, hello everybody. Just to introduce myself, I come from Germany, so my English may not be as good as from all of the native speakers.
No excuses.
No, okay. Well, I mean, this is really a very interesting question. So, you do not, or your children, they do not inherit the mutation, for example, not the disease. but they inherit something that they are more likely also to acquire the particular mutation. And we think that the risk of your children also getting an MPN is 5 to 7 times higher than in normal people. But overall, the incidence is very, very low. And what is also interesting, that we know families, MPN families, and in these families, children may not have the disease, but grandchildren may have the disease. And then it's even more interesting that sometimes, you know about the mutations. So we have CHEK2 and chiraticulin. And it may be that you are positive for CHEK2, but somebody in your family is then positive for chiraticulin. So it is very complicated. It's very complicated. And in general, I believe that I only know one family from the literature. So, I mean, now you may think it is all very risky, but I don't think it is in reality the case. So this is all that has been found by statistical analysis. So in general, I would say there's not really an increased risk that your children inherit the disease.
So to take that one step further, this is something that I would try to handle as a kind of FAQ in a conversation with a new patient. Should I run off and get my family members tested for this condition? No.
Yeah.
It's a short, I'm like Professor McMullen. No. So what is the kind of statistic? About 1 in 25,000 people get struck by lightning. Because you have this condition, you're 1 in 100,000. The risk of your family member having this condition is something akin to them being struck by lightning. There are some families in the UK, and Professor Mead is running a banking and detailed genomic study to look at that. And we're trying to collect some of these families, but it's not whole families. It might be an auntie and a niece. So just to reassure you, it's really unlikely. Maybe some people in the audience think about their questions, and I could read one out, and then maybe Naumann. So Anna, I think I might ask you this question, if that's okay. Will early or pre-fibrotic myelofibrosis inevitably transform into full-blown MF, or can it remain as it is, an entity separate from MF? And that's come from Yvette in South Africa. So hello, Yvette, from everyone here in London. And Anna.
So thank you for the question, and how exciting to be having a question from South Africa. So there is a lot of controversy in the field. I think it's first worth starting with that. So in case anyone hasn't heard of prefibrotic myelofibrosis, some of you may never have heard of that condition. In recent years, there has been a description of a category of disease which is not quite ET, it's not quite myelofibrosis. It has some features that some clinicians would actually describe that patient as having ET, but when you look at their bone marrow, there are some features that don't quite fit, and they have other features that are a little bit more akin to myelofibrosis. And what we know about that group of patients, if you consider a very large patient of a very large group of individuals who have some of those characteristics, is if you look at them over the course of time, they are more likely to develop into myelofibrosis. But of course, that's an average, and what we're interested about is individuals, and by definition, not everyone in that group of people will do the same thing. So by definition, therefore, there will be some people who will not develop into myelofibrosis, but on average, the risk is slightly higher than an individual who has ET.
Great, thank you. I mean, I think the overall statistic, if you look at the studies, which have followed patients for around 20 to 25 years, is that roughly 75 to 80% of patients do not change from prefibrotic to overt fibrosis. It's one of the problems we think with the name. I don't know if anybody else on the panel wants to comment on that.
Well, and from my point of view, there has now also been a bit of maybe an overdiagnosis of prefibrotic myelofibrosis, at least in my country. And it really, I mean, I will present that in my talk later. I mean, it really depends on the so-called megakaryocytes in the bone marrow. And I think we have so many other techniques and also the genetic techniques. And I think that if I had a very young patient and for this differential between ET and prefibrotic myelofibrosis, I really would like to have the bone marrow biopsy with a very good pathologist, because otherwise I would, in my letter, I would still keep both possibilities and say we really have to look the cause of the disease, because I find it very difficult to see young patients with having a change in their diagnosis, for example, just because a random biopsy was taken from ET then to prefibrotic myelofibrosis. They check it up in the internet and they really feel very bad that this is now a disease which is much worse than ET. And I really try to say, calm down and we will see what is going to happen in the future.
So there is an entity called NPN Unclassified, also called NPNU, which some of us actually use, sometimes because not every time are all the features present that would allow us to be more definitive about a diagnosis, so that can be helpful. Naman, do you have any questions on the internet?
Yes, there's one from Andrew Singleton in the UK who's asking, it's quite a thorny question, so it's, should we be asking our hematologist to switch from hydroxycarbamide to PEG interferon, so it's a PV patient?
So Adam, would you like to answer that question?
Well, I think, first of all, I think right at the outset, when you're thinking about the first line treatment, I think one should always ask the question about whether the first line of treatment should be interferon or hydroxycarbamide. But once a patient's established on hydroxycarbamide, if they're doing well and the blood counts are normalized, I think it has to be a pretty strong argument to take them off a treatment that's doing well and switch them to a treatment where they might get new problems, new side effects. So I wouldn't typically do that in my practice, but it is a conversation that comes up quite often, and occasionally, we reach a conclusion between myself and the patient that that's what they would like to try. And we do it occasionally, but I think it depends on many factors, but in particular, how is the patient doing on hydroxycarbamide? If their counts are normalized and they're feeling well, there isn't a strong argument to switch, and there are risks of switching.
We did just hear also from the world's most massive enthusiast for interferon, our friend Jean-Jacques Collagen. So, I think that therapy choices are individual, and I see Ruben wants to come in here too.
I just wanted to comment in that Claire and I and others were involved with an international randomized study from the MPN Research Consortium, asking individuals that had high-risk ET or PV up front. They were randomized between hydroxycarbamide and interferon. And we found that through a year, there was no difference between the two. Now, in many ways, that was positive. It showed interferon clearly had activity. There had been controversy around that. It clearly is a good drug. Whether it is a better drug, I think might well depend on the individual. Now, that was in a study that was kind of upfront. Now, a different scenario is if you're already on hydroxycarbamide and doing well, the bar for switching really then becomes that much higher, because there have been many, many patients who've been treated with hydroxycarbamide for a long period of time with PV or ET and have done very well. So frequently in these sort of meetings, one drug can become, much more kind of glorified than another, but there are really scenarios where individuals have done very well with really either drug. So someone doing very well on hydroxycarbamide, there's really probably no evidence to suggest changing solely at that point. Much more justified if you're not doing well on hydroxycarbamide, then it's a much more important discussion.
Yes, and Andreas, you want to weigh in?
Well, to answer this question, we should probably also look to other countries. So, for example, in Italy, hardly any patient is treated with interferon, or every patient with hydroxycarbamide. If you look to Scandinavia or also to France, many patients are treated with interferon. And I'm not aware that patients in Italy or in Scandinavia live longer with their disease. So I totally agree with Adam. As long as you have control of the disease with one of the drugs, there is no real reason to change it just because of the prospect that the other drug, you always think something else may be better. But, there may be more toxicity, less control of the disease. I mean, I would keep you on the drug as long as it is doing a good job. So,
And as you know, in the UK, we're good at taking back control.
Thank you for the bomb. Right. There are quite a few questions that came in online. I'm going to come back to the audience in a minute. I feel like I'm doing a political debate now, right?
Is the term Hydrexit now trending online?
So, before I come back to the floor, there were quite a lot of questions that came in online about different formulations of interferon and their availability across the UK. That currently standard interferon is being phased out, and the only form of interferon that is available is pegylated interferon. We have a newer type of pegylated interferon that has been approved by the European Medicines Agency. We have doses for 2 patients in the UK, as far as I'm aware at the moment. So it's not about can I get pegylated interferon anymore or not. Everybody should be able to get interferon. Occasionally there are some hospitals where it's proven difficult, and as a haematology community, we try to work together to make that actually happen. That's something that very much came from the National Clinical Trials Group, actually, is some of us had written business cases that went to our hospitals to justify the use of that interferon, and we passed it all between ourselves and shared it with our hospital colleagues. Anyway, so now maybe we'll come to the floor again and see their questions. There's one just here. Who's got microphones? There's a lady with a mic just behind. Should we do this one and then we'll come to you, Toby? Yeah.
I think it was Professor McMullen who mentioned difficulty in getting hold of control group. Is there an argument for longer term to set up a register of control group volunteers through the MPN and one of the hospitals, in the same way that Oxford University has a control group for brain diseases and brain degradation through things like Alzheimer's, through a collaboration with Warneford Hospital? That register's got about, I think, 1,000 people on it.
Yeah, that's an interesting point. I mean, there's a whole literature behind control groups for epidemiological studies for this. I mean, at the end of the day, you need funding to do that more than anything. But you're actually trying to get controls at the time you do the study, and trying to get, ideally, the phraseology is age, sex matched. So you want people about the same age as the patients and about the same age, about the same sex preferably. And it's always difficult because, what's the motivation for the control to do this, which is what it's all about. So you could do that, but you still would have the issue that, when you actually did the study, would that group do, or do you need older people? So there's a much bigger literature around epidemiology than MPN, and it's usually recruiting them at the time of the study. The best control group are the sort of random GP ones, but the point of our study was that you just can't get those people to come on board, because what's the motivation for them?
I was just saying that Oxford has a group of volunteers, about 1,000 strong in the Oxfordshire area, and they have a list to go through and can check on age and sex and general health before, and they just send out emails to individuals.
But the control group for this, nothing against Oxfordshire, needs to be much broader than that, because you're trying to get them for the same background as the patients right across.
I still think it's an excellent
but
point there. That's a really good contribution.
If you could do that broader than Oxfordshire, it would be an excellent idea.
But we could still learn something. So, Toby, you had a question? No, somebody behind you? No?
Yes,
if not, we'll come here. Yeah.
Thank you. I hope you don't mind me asking. I've been on hydroxyamine now for the past 20 years. I attend King's College Hospital, but unfortunately my platelets were very, very high past year. So they stopped the hydroxyl. I'm now on a new drug, Buscopan. But unfortunately, I only was asking if the hydroxyl would cause cellulitis on the legs. I'm now suffering with the ulcers on my legs. Would the hydroxyl cause that? They stopped me, and I'm taking this new drug now, Buscopan, which has reduced the platelets, but it does make one feel very, very dizzy. I go to King's every 8 weeks, and I'm only concerned about the ulcers on the legs, if you don't mind me asking.
No problem. So I'm going to depersonalise that, because we very much it's really dangerous to give a personal opinion. But maybe just to talk about complications of hydroxycarbamide, especially leg ulcers, and then also about busulfan, which is the drug that you're currently taking, and how that could be useful. Naman, maybe we could hear your voice. Do you feel comfortable with that?
Yeah, so it's very difficult when people have a complication on hydroxycarbamide choosing a second line agent, and there are several out there, so I'm not sure what options people have offered when you fail hydroxycarbamide, but options are busulfan, as you say. There's another agent called anagrelide that can be used, and then you've heard about interferon as well. And it's those discussions that when someone's failed the first line agent, I then outline each of these other alternatives. I have my preferences, but busulfan is a very, very, it's usually a very, very well tolerated drug, and it's given in different kind of schedules, and you can often find a schedule which is acceptable to a patient, and it produces, in my hands, a very durable response. So I think busulfan as a second line agent is a very, very acceptable alternative to hydroxycarbamide. But there are others that you can, if that is not acceptable to you, there are still others that you can investigate and speak to haematologists about.
And just a warning about leg ulcers on hydroxycarbamide. Haematologists don't often look at their patients' legs, right? And we do sometimes have patients that develop leg ulcers. It is a fairly uncommon but very, very difficult side effect of hydroxycarbamide. And to cure the leg ulcer, usually you have to stop. So there's no choice, really. Good. Yeah, great. Sounds good. This lady.
Oh, thank you. Thank you all very much for being here as well. I wonder if you could, one of you or somebody, say a little bit more about the significance of JAK2 positive R617, because I only noticed recently that issue and what that actually means, the R617.
I'm going to ask for a volunteer on that one. Are you reading that in the context of the 46-1 predisposition, JAK2? Is that what you're talking about?
I'm talking about JAK2 positive with a mutation of R617, which I've seen up there on the...
Thank you, Adam. Go ahead.
Probably mean the V617, which is so the unusual thing about the JAK2 mutation when it was discovered, and the quite remarkable thing when it was discovered, is that these genes are quite big. They encompass a large region of DNA, and everyone is counted in numbers, so from 1 up to 1,000 sometimes. So at position 617 in the JAK2 gene, that is a hotspot where the mutations nearly always occur in exactly the same place in that gene. So that's why you will see the V617 always coming up, because people that have a JAK2 mutation nearly always, not quite always, but nearly always have exactly the same mutation. So that's the significance of the 617. It's the mutation always occurs at that what we call a hotspot. Yeah.
Okay, another question from the room.
Thank you very much. Do you think it is better to have an algorithm in dealing with MPN? Because some of the hematologists will just willy-nilly do something that is for me, are toxic, rather than starting with less toxic drugs. And another thing is there any targeted treatment that is less or non-cytotoxic? Thank you.
Ruben.
So,
I'm
well,
asking you because I'm just going to preface this. So you asked about an algorithm initially. I'm asking Ruben because he recently chaired the NCCN guidelines, which are the North American guidelines for the management of MPN. In the UK, we also have the British Society guidelines, which have been authored by actually almost everybody around the table. But so I'm going to come to you, Ruben, and then I'm going to ask for comments elsewhere.
Perfect. Well, it's a very good question. So guidelines or algorithms are incredibly helpful. And what they are exactly is guidance based on clinical trial data, if there's clinical trial data, scientific evidence, and expert opinion all put together to try to describe for physicians based on a certain situation, someone's age, risk, etc., what treatment should we consider? Now, frequently, there is not one exact recommendation. There's sometimes more than one, depending upon the situation. So they are a guideline as to what are the guardrails of therapy. So, for example, for frontline therapy for high-risk polycythemia vera, in the United States, the physician has a choice of hydroxycarbamide or interferon. And then those guidelines provide some examples as to what features you might consider in each patient to decide between those two drugs, if there's not clear data showing that one drug is better than another. So there's definitely guidelines out there in the UK, in the US, and many others. And these guidelines, although there's slightly difference between countries, they're largely almost superimposable. I mean, there's quite a bit of similarity. Now, it relates to which therapy in terms of treatment, that, of course, is part of the effort that all of us are undertaking. You know, most of the therapies for MPNs are able to reduce the number of cells. And in that way, most overtly, they are cytotoxic, meaning they decrease the number of cells. Now, how they decrease the number of cells can be different. You have the drugs that truly are sort of chemical poisons that impact the DNA to cytotoxic those cells or to kill those cells. Hydroxycarbamide, busulfan, other chemotherapeutic agents kind of fall in that category. There are the interferons, which work through a different way that they impact cells. And then JAK inhibitors impact how cells grow and divide in yet another way. Now, which therapy is best, again, is a discussion between you and your patient, but typically kind of what's within that guideline. So if I wanted to use a drug that I used, let's say someone uses in breast cancer, and I wanted to apply it to MPNs, that would not be in the guideline. There would not be a justification for that. In the US, no one would reimburse for that drug. In fact, that could be held liable for malpractice for giving a drug that there was not good evidence. But between the drugs, that's really a discussion between you and your physician, and then weighing a lot of those pros and cons. Age, how well you've done with the drug, other health problems that you have, etc.
I would also add, just seeing if anybody else wants to say anything, that, you know, sometimes the algorithms or protocols or guidelines are a bit unclear. Professor McMullen has produced 2 very big documents for managing PV in the UK. They are the most downloaded documents from the British Journal of Haematology website. But that sometimes, you know, we have to individualise. If a patient's spleen is increasing, but not how much it's increasing, for example. If the platelet count is going up, but not always how much it's going up. So we have to sort of rely on a conversation around that. But does anybody else want to say something, Mary Frances?
Done a lot over the years in producing guidelines. They can only be made around the evidence that is available. So, you know, so they have to be updated every so often when there's new evidence. And you can end up with the guideline making a recommendation and second line choices and things like that, but it's with the evidence that is available. The caveat has to be that these are guidance. You cannot mandate this is what you must do. And in fact, that's very dangerous. There's been issues where guidelines have been issued and then they've been taken up by managers and said this is what you must do, and people have come to big trouble by that, because there's always the exceptional situation. But certainly there are MPN guidelines now for 15 years actually in the UK, and as Claire says, they're on the BSH website, they're open access. Many doctors actually access them, and other professionals access them at their desk, both in the UK and really much wider than that. And they're very similar, as Ruben says, to other guidelines that have been produced. But always there have to be guidelines.
Good. And a final word from Andreas?
Well, in my daily clinical routine, I take care of many patients with so-called rare MPN. I mean, so not with like myelofibrosis and polycythemia vera. And the problem is that there are no guidelines, because there are no randomized trials, no really scientific evidence, done in this way that it is really accepted by the authorities. So, but we now also try to write up something like expert opinion, and we really try to persuade our authorities that these expert opinions are also taken as enough evidence to treat patients with certain drugs, because we will never ever have any randomized trial. But if there is any patient with a rare MPN, I also want to encourage you to participate in registries, because in the future, these registries, for example, I take care of patients with a disease called mastocytosis. So many doctors, many hematologists have never seen a patient with mastocytosis, but I take care of more than 200 patients with this disease. Now we have a registry, and these registries, they really may serve as, we discussed that before, as a control. If there is a new drug, we want to offer the authorities with these registry data, and the registry data may really help to get approval of a drug. So this will really be the future. And I do not want only to encourage you to participate in these registries, but also in the other registries on the more frequent MPN, because in the future, the registry data will become more and more important, because the development of drugs will be so rapid that we won't have randomized trials. A randomized trial may take years, and drugs may come within months. And we really need registry data, and this is very important for you and for us and for the next generation of patients.
Very well said, thank you. So in the UK, we're launching a myelofibrosis registry. Actually, Naman Bhatt has been leading on that. It's a massive amount of work. We've set the field similar to the French registry so that we can make a comparison. We're also trying to launch MyMPN, which is an MPN Voice, MPN Research Foundation joint collaborative process. Actually, you can enter your data and we can look at it together if you give us permission. I think these things are important.
And a European one.
And eMPN, which you and I are leading. Yes, that's true. I'm so sorry. Yes. Fine, good. Any other questions from the floor? Good.
Thank you for the MPN Voice panel. My question is, with the hydroxycarbamide, is there a maximum amount of tablets that can be taken by individuals, and how is that measured against the symptoms that people have?
Hannah, comment on that? No? Yeah?
So I didn't hear you. Not strictly, but I think we were having a discussion about this this morning, in that if you read the guidance as to what is considered the upper limit for when formally in certain criteria patients are said to be resistant to hydroxycarbamide. That's actually a very high level of hydroxycarbamide, and actually for other conditions, very, very high doses of hydroxycarbamide are sometimes used, probably higher than anyone would be on in this room. So really the highest dose tends to come down to the side effects and the effects it's having on the rest of your blood counts. So there's a lot of variation in what people can be taking, but as an individual, it probably comes down to the other effects it's having on your other blood counts. So, for example, you're taking it for a high platelet count, what's it doing to your white cell count and what's it doing to your hemoglobin, and then what other side effects it may be having on you as an individual and whether you're able to manage those. But normally, by the time you're getting up to the levels that we're starting to think that's quite a high dose, that's normally mainly because it's having effects on your other blood counts rather than the dose per se.
Okay, good. So we'll move on. There was another question at the back. Yep.
First of all, thank you very much for the work you do every day for us. It's really, every day of your work is high value for us, every second. I just have a question for Professor Meza. I know in MD Anderson you have done some interesting research on mindfulness and the relaxation response. Could you please share with us a little bit more about it?
Great question.
Sure. So, and I look forward to kind of sharing greater details this afternoon as part of my talk as well. But I'm part of a larger group that is interested in MPN and quality of life. And overall, we realize that even with the best of the medical therapies we have now, whether you're on hydroxyurea, interferon, aspirin, phlebotomy, ruxolitinib, what have you, still most patients with MPNs don't feel 100%, and they still have residual symptoms that can range from being mild to very problematic. So there's a group of various collaborators looking at different aspects from diet, from yoga, from meditation, mindfulness, etc., to really try to see what else can we learn, what else can we bring to the table along with medicines. You know, I could say that in specific in the area of meditation, we've learned that there definitely is an impact. First, through yoga studies, where yoga has both meditation and physical activity parts. Meditation part, people have been responsive to it. They understand kind of what's being suggested, but it has had an impact in some of their symptoms, some of that through improvement in anxiety, some of that through improvement in sleep. We've been able to show that the improvements in sleep may correlate with improvements in inflammation and other parts. Additionally, there are some web-based approaches. We have partnered with a company called Calm that has an app-based meditation system that has a whole series of different modules that we've done trials on. And the initial trials, again, showing utility, people can understand them, but also showing improvements in a variety of things. Stress, anxiety, and sleep, which all tend to be big drivers of that piece. So we're looking to do some further studies, as well as take some of the lessons learned from MPN patients and try to apply them to others that face chronic diseases like MPNs to see how those might be of benefit.
Okay, great. Thank you very much. Naman, any questions online?
Yeah, there's a few. There's one that comes up quite often. My husband was diagnosed, this is from Jules Chirillo in the UK. My husband was diagnosed with ET 3 years ago, but never had a bone marrow. Is a bone marrow necessary to confirm the diagnosis of ET, or is it just by blood tests alone?
Asking, who should we ask for that one? Adam, maybe? Yeah.
Well, Jean-Jacques seemed quite keen on not doing bone marrows, I thought, earlier on, didn't he? So
I was quite surprised about that.
I was a little bit
Yes.
surprised too. So it's a little bit of a complicated one to answer, but I'll have a go. So the WHO international guidelines for how we classify disease actually requires patients to have a bone marrow test in order to formally make a diagnosis of essential thrombocythemia versus pre-fibrotic myelofibrosis. In the UK, we've adopted a different approach that I would tend to use in my own personal practice. I'm not sure a bone marrow is always required or helpful, actually, and it is an unpleasant test to have, and it's not without complications, particularly in patients with MPN. Although they're rare complications, people can have bleeding problems after having a bone marrow biopsy. So we shouldn't do them lightly. So in answer, I don't think everyone needs a bone marrow biopsy to diagnose essential thrombocythemia. In my personal practice, what I would do is have a look for any unusual features of essential thrombocythemia. So have a careful look at the cells down the microscope in the blood, look for any unusual features there. If the patient has an enlarged spleen, I would think about doing a bone marrow. If any of the other blood counts are affected, I would think about it. And particularly in younger patients, I would also think about it, because it can sometimes, even though it may not influence your immediate management, it can sometimes be useful to have a bone marrow as a kind of baseline test, so that in 5, 10, 15, 20 years, when someone runs into problems, you can say, well, this is how the disease looked back then, this is how it looks now, and that can be useful to kind of have objective evidence that things have changed.
Right, now I'm going to let Andreas in on this, but I'm going to let you all in on a secret. That bone marrow biopsy or not has been a bone of contention between UK haematology and German, let's say, pathologists, not our haematology friends, for quite a long time. So I could see him looking really wicked, catching my eye. So Andreas, please.
Well, yes, I was educated actually as a hematologist doing bone marrow biopsies in every patient and as frequent as possible. No, but I think we have found a compromise, and I totally agree with Adam. I would say the patient should have at least one bone marrow biopsy. I would like to have it at the beginning. And I'm saying that because I'm a hematologist who has meanwhile been seeing the same patient for 10, 15 years. And there may be a situation in the clinical course, your spleen gets bigger, you get symptoms, your blood counts change. And then I may want to do another biopsy just to see, is there new fibrosis? Is there more fibrosis? Is there something? And then, of course, I would like to have something to compare with. And then I sometimes feel that it is not very good if I don't have an initial biopsy to compare. If really also in the bone marrow has changed something. And the bone marrow is the primary place of the disease. So it's not the blood. So I like to have something to compare with.
I think fine. That's good. Naaman, any more from you? I've got a couple that came in before the meeting.
Yes, so there's another one which, again, is quite contentious. So it's from Jane Price in the UK. Why isn't stem cell transplant used in younger patients with a new diagnosis of ET and PV in an attempt to cure the disease?
Well, I think that's actually not contentious, personally. So who wants to answer that question? Mary Frances. Mary Frances, you make the
It is a logical question, without question. And anyone who says that, the decision around stem cell transplant is an easy one is not the person facing it. So we take the question very, very seriously. But I think the key is to understand really what is stem cell transplant. Stem cell transplant, or being a stem cell transplant survivor, is having an illness. Now, that illness might be mild, but that illness can range up to being fatal, the complications of going through a transplant or the impact of graft versus host disease. In short, the main reason is that even being a transplant survivor might be a worse illness than having ET or PV. So in the end, we truly, there's not controversy, but it's not, that we do it on a flippant basis. It's really about the risk. The risk is really just not justified, and that even if the transplant went well, what the life expectancy of someone that has gone through that might still be diminished having been a successful transplant survivor versus having ET.
So I would say that we don't have any transplant physicians particularly in the room, I don't think. But if we got a lot better at transplantation, if it was just like having a blood transfusion or like something out of Star Trek, then of course we could do that. Of course we could take out your stem cells, edit out JAK2 and put it back. And of course we're having the discussions about, is that possible? But it sounds so simple, but it really isn't, unfortunately. Nauman, any more from you?
A couple more. So Jeanette Martin from the UK wants to know the significance of having an MPL mutation with her diagnosis of ET.
I feel, Anna, you should answer that one.
Okay, so MPL, MPL mutations. So these are the least common of the recurrent mutations that we find in ET. So around about 5 to 10% of patients with ET and MF will have a mutation in the gene MPL. So as a result, it's the smallest group of patients we have, and so it's the smallest group of patients to study, but nonetheless a reasonable group of patients, so we know a little bit about them. In terms of how we look after those patients, we don't really do anything differently to how we would look after those patients if they had a JAK2 or a CALR mutation. Sometimes, I'm just thinking about if there's anything really that we see very differently to the clinical features. So for example, we do know, and I'll mention this later, that patients who have a JAK2 mutation have a slightly higher risk of blood clots than people who have a CALR mutation. MPL probably falls somewhere in between the two. So there aren't really any distinctive features of that MPL group specifically. But it's the smallest group we look after, and it doesn't really change how we look after them.
Okay, so maybe one more from you, Nauman, if you've got one. Otherwise, I've got a couple.
Yes, so this is actually the last online question. It's asking whether ET or its treatment with aspirin or hydroxycarbamide affect hearing, particularly tinnitus or hearing loss.
I think I'll answer that. So that's actually quite a tricky question. I think it's much more likely that there is another cause for tinnitus, which is a noise in the ears, or hearing loss. But, you know, these are always things that it's useful to bring to your haematologist. Important to think about simple things like wax in the ear. Tinnitus is actually very common. I think it's very unlikely to be due to your treatment, but write the question down. Ask your clinical nurse specialist or ask your clinician. Good. I've got 2 other questions online, but I want to come back to the room and ask other questions from the room. Yes, we didn't ask you before. So instead of coming back to someone who's already asked, could you just come over here? I'm really sorry, we didn't let you ask Jean-Jacques. Yeah. And then Chris, yeah.
My question's about epidemiology and the fact that the majority of people with MPNs, they're diagnosed in their 50s, their 60s, their 70s. For epidemiologists, that must be a nightmare, because trying to remember what people did last week is hard enough. Trying to remember their life over 60 years, even more difficult. Has there been any thought given to looking at much younger patients with MPNs, because they haven't got as much life history to identify, and also for many of those patients, they will have parents who can assist in the recall process. So they can actually tell you that, oh, you don't remember when you were 5, you always used to go out and eat soil in the garden, or that at 3 years old, we moved out from the house that was under the electric pylons or away from the municipal incinerator.
That's a great question. So I was going to link that into a question about what happens to young patients, but I'm not actually going to do that. It's a really, really good question. I think, Mary Frances, that has to be your question. Yeah. I would say that I think that it's quite possible that the disease is a bit different in younger people than it is in older people. That's something we would have to bear in mind. But please, for you, Mary Frances.
So you're quite right. It's a nightmare. And that's what the whole epidemiology studies are directed towards. The people who do the epidemiology studies are asked to fill in a questionnaire beforehand, so that you're not just getting on the phone and expecting them to remember this stuff. And a lot of it is, what occupations have you had in the past? What are your where have you lived? Where are you postcode? So it's trying to sort all that out as much as possible. And then the questionnaire systems are devised around the information. So if somebody says they worked at such and such, then the OCI days, as it's called, prompts a load of other questions to try and explore the things that patients would have been exposed to in the past, so that they don't have to just remember it all. Like, it's very carefully worked out. The young patients, I think it's, as Claire said, you wouldn't want to do it all with young patients, because I suspect there will be lots of young patients in the studies and will want to participate, but you wouldn't want to do it all with young patients because they may well be a different group. But certainly there's the opportunity, once the studies are done, to perhaps look at the young patients and see if there's anything different from that.
Great. I want to come to Chris.
Yeah, I appreciate we haven't got a transplant specialist here, but I guess at some point you guys will be discussing with your patients a transplant. If so, what do you offer them as a percentage of success for a stem cell transplant?
So I might ask Ruben to cover that in his session. Do you feel able to cover that? Oh, sorry, Andreas, you're talking about myelofibrosis, because this is a difficult question, right? Because you have to look at the patient in front of you, how fit they are. Transplant is a bit like running a marathon, not once, but 6 times in the Sahara Desert, like the fundraiser we heard about this morning. So it's about the fitness of the person, how good the match is for the stem cells, and then how bad the disease is. So the outcome is tailored to that. And then it's tailored also, now we added mutations into how well a patient might do after a transplant. So it's actually really complicated. So you end up giving a fairly broad answer, and then you would tailor it to the patient in front of you. So I appreciate that might not be the specifics of what you wanted, but it's impossible to kind of say broadly. I would say 15 to 20, 25% risk of dying, maybe 40 to 50% chance of success, but that would be completely different for a really young patient where we're transplanting them for a slightly different reason. Anybody else want to weigh in? Adam?
Just, in my practice, I steer away a little bit from having that conversation, and then I refer to the transplant team, because everything is so, subspecialized now, even within hematology. And there's a process that the transplant doctor will go through to determine the risk, and there's very well developed what are called comorbidity risk scores. So when a patient sees the transplant doctor, they will enter in all sorts of different variables about them, their age, their sex, their other diseases that they've had, and some information about their disease and donor status, and that will much more precisely for an individual patient predict the risk.
Yeah. I've got 2 more questions online, but are there other questions in the room? I think that was a really good question. Yes, Adam.
So, first of all, thank you very much. One of the things that comes across very clearly is there are different opinions and different approaches to how you treat various diseases in different countries. And I suppose the question is that normal? So one of the things that, patients here will come across is perhaps a sense of confusion. And I'm wondering, if you were dealing with another set of diseases that were similarly rare, would you be having the same conversation that we do it differently in Italy than we do it in Canada or whatever?
So I will give my impression of that. I think we injected some humour here and some little bit of, correlations between the countries in Europe. Some of the differentness, like no interferon in Italy, is around the reimbursement of the drug. In Italy, they give all their polycythemia vera patients aspirin. They reduce their hematocrit to 0.45 based on studies that were done internationally. So the kind of targets of treatment are very, very similar. Some subtle nuances, doing a bone marrow or not, and then availability of drugs. That's what's driving the type of treatment that gets given, I think. And I will let you answer that also, Andreas.
No, because I think this is really such a very good question, and
Yeah.
it also. I mean, if we as specialists are in a session with the super specialists, and if you listen, let me say, to a very important representative from Italy talking for 30 minutes on hydroxyurea or hydroxycarbamide, even as a specialist, you think, okay, I have to treat every patient with hydroxycarbamide. And the next speaker, maybe from a Nordic country, giving his presentation on the advantages of interferon in the same disease. He's talking about 30 minutes about that. And this is also the interpretation of the scientific evidence. And then you feel, okay, I have to switch every patient from hydroxyurea to interferon. So, and that's really the difficulty. I mean, we would need, endless number of clinical trials to answer that. And it's just not possible. And I think finally, it really comes down to our individual experience. If you come, if you have an experienced hematologist in ET and myelofibrosis, and I think also the differences are not that massive that you really, as I said before, that you must be scared that you are treated with the wrong drug. I think there are not really that big differences.
I would say that any treatment decision is not made by one person. Certainly in the UK, NICE not only tells us which drugs we can or cannot use, they also mandate that we do a conference meeting to discuss, A, do we agree on the diagnosis, B, do we agree on the treatment? So that involves different clinicians, often also the pathologists, for example. I think if we were to look at our colleagues in other disciplines, in oncology, in respiratory medicine, there would be these nuances of slight difference in care. And it happens also when we have choice. And having choice is also a good thing. And Ruben, you want to say something?
I completely understand the distress, and having been involved with many patient meetings over the years, folks can come away and say, these folks can't agree on anything. And they might be right. But in all candor, actually there's tremendous agreement, and really what we discuss really then are the subtle points. Medicine truly is art and science. And the discussions we have here are no different than if we were talking about congestive heart failure or how we manage lupus or how we manage preterm pregnancy. I mean, truly all of these, there's variability. The science is all of this information in aggregate. The art is how that really then applies to you. Because any one of you might have a disease, the same blood counts, the same mutation profile, but you're very different individuals. And which therapy might be the better fit, might have many factors, including the experience of how well the first treatment really applies to you. So both there's the initial decision, but then there's the art of then how do you adjust the therapy or change the therapy based on how you respond. So both art and science, but probably as organized in MPNs as really other areas, because it's an area that's been very collaborative. It's been an area of great discussion and cooperation between folks really around the world working on these diseases.
Yeah, usually we're pretty friendly and usually we agree with each other, right? Mostly, right. Are there any questions in the room? It's 1:00 and it's lunchtime. Yep.
Okay, I'm really conscious about not hogging the limelight, but I'm going to make the most of such an esteemed panel now when I have them. I'd just like to know, what are the chances or the risks of developing myelofibrosis or advanced myeloid leukemia if you have essential thrombocythemia?
Okay, so
And
that
how long?
question came in online as well. You may have submitted that. I've got that on a sheet here. So I think that has got to come to Anna because you're being asked to present on ET. The question, you've heard the question in the audience. The question here is also related to when you're at a young age at diagnosis. I mean, you discussed that yesterday with our clinical colleagues. Will you start the answer and then maybe someone else also speaks?
Yeah, so So the numbers that come out of the studies are very variable, and it does depend on your age. So I can't give you, so it's very difficult to give a number, but broadly the risks of developing myelofibrosis, think of in the region of 5, 10, 15%, and AML will be smaller than that. We know that there are factors that make you more or less likely to develop, to have one of those complications. And we know a little bit more about that from recent studies, particularly some of the more recent genetic studies. But probably most patients with ET wouldn't have very comprehensive genetic studies done at diagnosis, because we don't necessarily know what to do with that information. So those are the very broad figures, but they're slightly different between different studies. That's over kind of potentially a lifetime of disease. So it's, those numbers are not necessarily helpful for individuals, but those are the kind of studies that are quoted.